Hi, I'm Duncan Ferguson, and I first want to thank the International Veterinary Students Association for inviting me to uh, give this vet talk. I'm going to be talking about the international perspective of drug therapy, and in this particular section, we're going to talk about a day in the ICU, intensive care unit at two universities in the US and in Germany. I'm a professor emeritus of veterinary clinical pharmacology at the University of Illinois and also president and chief medical officer of VetMedAcademy. Before I go any further, I want to make sure that anybody who has questions can email me at either one of these email addresses. So what I'm going to do is give you a little bit about my background as requested, and then move into my international experience as a Fulbright faculty scholar at the University of Hanover in Germany, where I spent the total of 2 semesters in at that university. And then we'll compare what I call just a snapshot of drug care in the intensive care units at our Illinois school, University of Illinois, and the one in Hanover. And we'll compare those top 5 drug classes, mainly just in terms of how they're used. They will obviously not be able to talk in detail about each drug class, but I'll give you some references and other videos you might want to view about those drug classes. And then we'll summarize. Briefly, a little bit about my background. I got a degree in chemistry and then got my veterinary and PhD degrees in a combined degree program at the University of Pennsylvania, where I got my PhD in pharmacology. I continued there in a small animal internal residency, after which I became board certified in small animal internal medicine and later during my faculty career in veterinary clinical pharmacology. During my career, I've had the pleasure of working at Cornell University for 20 years at the University of Georgia, and then 10 years as a department head at the University of Illinois. And I'm now an emeritus professor at the University of Illinois and the co-founder, president, and chief medical officer of VetMedAcademy.org, a nonprofit organization I'll talk a little bit about later. You might be wondering how I got the perspective of drug therapy in Germany. Well, as a U.S. Faculty member. Well, I had the honor of being a Fulbright faculty scholar in 2013, and I also visited again in 2016 the University of Hanover in Hanover, Germany, and worked in the small animal clinic as well as the e-learning institute. And what I focused on in my teaching and research there was on how to facilitate critical clinical thinking for students. And it was a very interesting experience to compare that in US students to the German students, and how the different educational systems for veterinarians brought them along in different ways. So I wanted to give you the perspective of what you might see in a day in the intensive care units at the University of Illinois and the University of Hanover. And here's the entryway to the University of Illinois and the entryway to the University of Hanover. They have a very beautiful school, fairly new, and a different campus than it was before for the small animal and equine patients. So here we'd be in a rounds setting at the University of Illinois. And on the right, you can see in that what I attended at the University of Hanover was basically rounds that were cage by cage discussions of the usually diagnosis. And so I found myself listening to the diagnosis, learning the terminology, and then I would sort of linger behind and read what they actually wrote about the therapy and what they did, and talk to the clinicians afterwards about their therapy and their rationale for these cases. But it gave me a very good insight into the thinking about case management, at least in the intensive care unit at the University of Hanover. So what I'm going to do is to show you the drugs that were the top 5, if you will, in the ICU at the University of Illinois, and then those in Hanover, and they're the same classes of drugs, but I wanted to note specifics about each one. So the five classes of drugs that we saw in greatest frequency were, of course, fluids that include oncotic agents, not only things like balanced electrolyte solutions, but oncotic agents like hetastarch and plasma, antimicrobials, pain relievers, and there's some interesting differences that we'll talk about between Hanover and the United States approach. Glucocorticoids and antacids. Now, turning to the University of Hanover, I wanted to note that one particular fluid stood out, Sterofundan, and anything in red here will be things that were fairly unique, not unique, but were different about the University of Hanover. So oncotic agents were also used, so that was similar to Illinois. And antimicrobials they preferred were potentiated penicillins and then metronidazole, doxycycline, cephalosporins, and aminoglycoside, gentamicin specifically. For pain relief, this is I'll talk more about this, but they really focused on the use of a drug that's used almost not almost, isn't used anymore in the United States or the UK, called metamizole. We would also potentially call it dipyrone. And they called it Novalgine in German. And it was used on almost every case for managing pain relief in the critical care arena. Glucocorticoids, they used most of the ones we use, but didn't see a lot of dexamethasone, interestingly. And antacids, they preferred to use the proton pump inhibitor, omeprazole, and did not use sucralfate. We'll talk about those in a bit. So what I'd like to do now is to hit on the highlights of the different classes of drugs that were used at the two clinics. And starting with fluids, at the University of Illinois, lactated ringers and plasma-lyte. And I'm showing you excerpts from the actual record so you can believe that these are real cases. And there's a real picture of a fluid drip. These were the types of fluids, and we'll compare their composition in a second. But I don't have time to go into great detail here, but I do want to refer you to more videos on fluid therapy, and specifically the one on types of fluid therapy on the YouTube channel of VetMedAcademy. So the fluids that were used most often in Hanover were called Sterofundan. And this is the term that's used in many of the EU countries, also known as Ringelfunden in Scandinavia, Slovakia, and Hungary, and Isofundine in France. And so basically, these are used for long-term therapy, intravenous fluid therapy, or subcutaneous fluid therapy because they're replacement types of fluids. Now, this slide is a little bit busier than I'd like to use in a talk like this, but I wanted to suggest that you stop the video and take a look at it and use this as a reference. The main points I want to make are comparing the types of fluids that are used in Illinois, LRS, and Plasma-Lyte to those of Sterofundan in Germany. And you can see that all have similar sodium concentrations to plasma, all have similar potassium concentrations to plasma. Plasma-Lyte doesn't have calcium, but the others are similar to plasma, same as magnesium and chloride. And then the difference boils down to what is the bicarbonate equivalent, as we call it. Whereas there is real bicarbonate in plasma, you see that in fluids, you use agents that are converted, such as lactate and lactated ringers, or acetate in Plasma-Lyte for rapid conversions, same in Sterofundan. And then there are longer acting types of agents that are converted to bicarb, like gluconate and maleate. So these are replacement crystalloids that have very similar composition. So the second class of drugs that one saw at both clinics really were antimicrobials, and I want to highlight the one that was used very frequently was potentiated penicillin called Unison. That's the trade name, as you can see here, but it's really ampicillin and sulbactam. And it's a potentiated penicillin that's widely used in Illinois because it can be given IV, sub-Q, and intramuscularly. It has a better gram-positive than the gram-negative spectrum, but if you're looking at managing, say, a urinary tract infection, it has reasonably good E. coli efficacy because of the concentration one can achieve there. The problem with its use sort of as a routine is that it can lead, as any antimicrobial, can show long-term resistance. The next antimicrobial that I wanted to talk about was metronidazole, and it's a drug that's effective against anaerobic bacteria, trichomonads, giardia, and coccidia, and it was used in both clinics, really in the clinical critical care area to facilitate four-quadrant therapy. That is, the attempt to treat gram-positive, gram-negative, aerobic, and in this case, adding anaerobic activity. This was a drug that was often added for that purpose. Doxycycline was the next drug I want to talk about, and it was an antimicrobial used at both clinics. It's a broad spectrum agent and may even be cidal at higher dosages. It was used for broad spectrum therapy primarily in Hanover, whereas Illinois used it for specific microbes, the rickettsia like Borrelia rickettsia, and also leptospires, chlamydia, mycoplasma, bartonella, and bordetella. And finally, turning to the antimicrobials targeted at gram-negative organisms, we had parenteral cephalosporins, which can be given by IM, IV, and sub-Q routes. And these include first-generation cefazolin and third-generation ceftiofur, where the third generations have better gram-negative coverage and less resistance problems associated with cephalosporinases. The aminoglycosides were used in both clinics, and where gentamicin was shown at both schools, it was the primary one that was used at Hanover, whereas amikacin was also used in Illinois. The third class of drugs that we saw used in both clinics, but I want to talk first about the range of non-steroidal anti-inflammatory drugs that were shown in the United States, ranging from aspirin to carprofen to other drugs like meloxicam. These drugs, I don't have a lot of time to talk about, but I do want to refer you to this playlist on anti-inflammatory drugs on VetMedAcademy's YouTube channel. What's useful to report are the amount of adverse effects that can be seen with the non-steroidals used in the United States. And this is a report to the U.S. Food and Drug Administration that showed that carprofen had around a third of the cases had vomiting. And you can see that's true with meloxicam, maybe 20-25%, and again up to 30% with daracoxib. So for GI side effects are common. Around 10% diarrhea in all cases here, and also around 10% to 15% elevation of BUN reflective of nephrotoxicity. So these are drugs that we have to be a little concerned with regarding their side effects. Now, the University of Hanover, it was very interesting that the main drug used for routine pain management and fever management was metamizole, called in the United States Diprone. Clinicians in Germany claimed efficacy of this drug against visceral, that is GI pain, including antispasmodic effects. The interesting thing is that in the United States, this drug has been essentially discouraged, if not banned, from human use since 1977 and discouraged in veterinary use since 1996 because of the concern of its extra label use in food animals. And I remember vaguely as a veterinary student over 40 years ago, but it was mainly used for fever reduction. So how did this drug get such wide use in Germany, where it's essentially banned in the EU and in the United States for veterinary use? I think it just boils down to the differences in regulations of the various countries, and also the accumulated experience that the German veterinarians have with more safely using this drug. We'll have a discussion of this in a separate video about drug regulations between the countries. Now, the other class of pain relievers that I want to mention are, which were really, I only saw used in significant amounts at Illinois, at least in non-anesthetic situations, were the opioids. And here's examples of use of hydromorphone, fentanyl, and the oral drug tramadol. And of course, the issue is that these drugs are addictive to humans and therefore are regulated in very strictly in both countries. And yet we see greater use of them in the US system, at least for non-anesthetic scenarios. The thing that makes them so dangerous, of course, is that they can stop breathing by suppressing the respiratory drive in the medulla. They have other effects here shown as well. But that's the main reason that they become life-threatening if given in an overdose. The fourth class of drugs that I wanted to talk about were the glucocorticoids that we saw used in both clinics. And whereas in Illinois we saw prednisolone and methylprednisolone and dexamethasone, and Hanover, we mainly saw the first two. And these were used for anti-inflammatory immunosuppressive activity. Again, I want to refer you to more detail on the physiology and pharmacology of glucocorticoids and in the adrenal playlist on VetMedAcademy's YouTube channel at this link. The main thing I want to mention is that their beneficial effects are non-specific. That means they have effects regardless of the initial insult. And perhaps because of the use of the non-steroidal anti-inflammatory drugs and glucocorticoids in the critical care setting, we saw the use of antacids and anti-ulcer drugs. And the first one I wanted to talk about that was used almost exclusively in Illinois, not in Hanover, was sucralfate, which is an orally administered drug that can be given to bind essentially ulcer exudates and act as a protectant. And its indications are reflux esophagitis, stomach ulcers, questionable whether it's effective for intestinal ulcers. And so here the question is whether they should be used as a prophylaxis for all hospitalized animals because of stress, or whether they're have glucocorticoids or NSAIDs on board. The point being that they still have drug interactions and adverse effects that include the fact that they their action can be diminished by other drugs, meaning you have to alternate the use of sucralfate with other antacids. So there is adequate acidity to allow the activation of sucralfate. In addition, sucralfate, being an orally administered drug, has a tendency to bind to and prevent the absorption of other drugs administered orally. The other antacids or anti-ulcer drugs that were seen in both clinics were the proton pump inhibitors. Omeprazole was used a lot in almost every case in Hanover, and pantoprazole was also used at the University of Illinois. These are hydrogen pump inhibitors, hydrogen potassium ATPase inhibitors, and they're indicated for diagnosed gastric ulcers, maybe intestinal ulcers, there's a question mark there, and some, and this is what I think most of the uses were in the intensive care unit, were prophylaxis against gastric ulcers, where the clinicians believed that these animals were stressed. Now, there is evidence that these drugs are better than the H2 antagonist famotidine for reducing ulceration and working Alaskan sled dogs. But the question of whether they are necessary or effective in hospitalized animals that are just there because we think they're stressed or because they have an NSAID on board or glucocorticoid, that uh, remains to be seen. And that's an entirely another conversation to talk about whether the use of these drugs is an overreaction or not. So with that quick review of the top 5 drugs used in the ICU in US clinic and in Germany, I hope you're not feeling like the central character in Edvard Munch's The Scream. If you take drug therapy systematically, you can learn how to break down and justify uh, therapy that's being used in a clinical setting. It takes a little bit of practice, but if you use a good formulary and you approach it that way, you'll be in good shape. So in summary, the top 5 drug classes in the critical care setting in the US and Germany were fluids, antimicrobials, pain relievers or anti-inflammatories, glucocorticoids, and perhaps as a reflection of the use of NSAIDs and glucocorticoids, anti-ulcer drugs. Differences were noted in selected drugs within a class based upon the federal drug regulations, which I'll be talking about in a subsequent video, and probably clinician experience or preference, and ultimately the flexibility for extra label drug choice, which we'll talk about in terms of a regulatory factor that differs between European countries, at least, and the United States. And finally, to talk about one class of drugs and specifically that popped out at the end, anti-ulcer drugs, particularly proton pump inhibitors, were overprescribed in both clinics, presumably with the idea that they're managing or preventing ulcers in the face of stress, non-steroidal anti-inflammatory drugs, or glucocorticoids. Finally, I wanted to invite you to visit VetMedAcademy. It's an open source veterinary educational resource for students and faculty. You can register for free at the link I show here. We've been collaborating with the IVSA since 2016 and now have a member module for those that are IVSA members. We separately have partnerships with Clinicians Brief and Plum's Veterinary Drugs and the MSD or Merck Veterinary Manual, and offer premium boot camp courses that have included the Approach to Physiology series and an Approach to Pharmacology series. And we have a partnership with vetlibrary.com, which allows us to provide a database of free access of PDF, full text, veterinary text for VetMedAcademy members. Thanks again to the IVSA for inviting me to do this vet talk, and I want to encourage anybody who has a question to email me at the email addresses that I gave at the beginning of this talk. Thank you very much.